So hi there, and welcome to this presentation of the use of neuromuscular ultrasound for the detection of tremor. This presentation was intended for the EAN 2022 conference in Vienna and supposed to be live, but unfortunately things happened and that was not possible. So this is a recording to share with you, and I would really love to hear your thoughts on the use of ultrasound for the detection of tremor. It's quite new. Our team has put a lot of effort in preparing this material, especially for this conference for you, so I hope you enjoy. This is actually the companion video to another video on the use of neuromuscular ultrasound for movement detection, and that one is about fasciculations and fibrillations and whole muscle movement. So I can highly recommend that first part. Now we're going to the second part about tremor. My name is Nens van Alfen. I'm an associate professor of neurology and a clinical neurophysiologist, and I work at the Radboud University Medical Center in Nijmegen, the Netherlands. And we do a lot of ultrasound of nerves and muscles, and I hope to share some exciting experiences with you. As you might know, we are also a Parkinson's and neurodegenerative disorders expert center, and my colleagues Anke Snijders and Helmich have helped me tremendously preparing this for you. So, tremor. It's not a common topic to be talking about in muscle ultrasound. We don't regularly use it yet. And when we see it, it's usually a nuisance. So just look at this video here. This was a lady with Parkinson's disease who presented with quite a severe median neuropathy. It was a iatrogenic lesion from a brachial artery needle stick that resulted in a large hematoma and damage to the median nerve. And while trying to scan the nerve for damage, she was so nervous about that she was really having a large increase in her resting tremor. So it's kind of challenging here to follow that nerve around, right? So this is maybe not when we want to see tremor, but if you look at the video, you can sort of imagine what you could be able to do with ultrasound in these patients. So we were thinking, what aspect of tremor could ultrasound help characterize for you? Could you look at the rhythmicity or regularity? I mean, is it a tremor, right? And there's even a stability index invented for that. Or maybe frequency from the ultrasound videos. The body distribution might be of interest, or the distribution between different muscles in a single body part, such as a forearm or a leg. Coherence, well, not sure about that one. Activating conditions, if the patient is at rest or is loading the weight onto the limb. You could look at entrainment maybe, or suppression by voluntary movements of the contralateral limb, the loading responses, as I said, and resetting. Well, we'll see about that. Let's look at the current classification of tremor. So this is a recent paper from Clinical Neurophysiology that divides these tremors in several large groups, and it all starts with the clinical phenotype, right? So if you're into tremor, I'm sure you've seen this before, and I'm not telling you a whole lot new, but the question for us was, where in this classification can we add value with ultrasound? And this is just a preliminary, exploration at this point, and I hope, again, you will share your thoughts with us. So we think basically that tremor might be of use to look at the regularity of a movement. Frequency, yes, possibly, but you see moving tissue and you don't actually see firing motor units or the brain oscillations. So it's sort of a tertiary step here, and we're working that out at this point. To look at tremor in a whole body distribution with ultrasound is kind of difficult, or comparing left to right is difficult, because you would basically need two time-locked ultrasound machines, and we don't have that at this point, at least we don't. But within a certain part of the limb that you can capture in your ultrasound scan, you can look at the, the activity or the amplitude of tremor, for example, in different flexors. Coherence, again, yeah, well, that's not possible at this point, but we might be able to look at activating conditions. So if you sort of fix the probe and have the patient either contract or assume a certain posture, you might see it. Entrainment, similarly, if the contralateral arm is moving with a different rhythm, you might see the rhythmicity change. Loading response and resetting, we are not quite sure, but that all comes down to stability of the ultrasound. So this too, like the fasciculations and fibrillations I talk about in another video, requires a technical setup. So this is just your general MSK setup. You need a linear or convex ultrasound probe with a frequency range that is typical for these probes. You need a sufficiently large frame rate. So you want to have at least a frame rate that is twice the frequency of the maximum frequency of the tremor. So if you are looking at a 7 Hertz essential tremor, you need at least 14 Hertz frame rate, right? Even preferably even a little bit more. You want to turn the image optimizers off again, so don't smooth away the movement. You want to capture this on video for analysis offline probably, and you don't need to do anything about temperature. That's not that relevant in this case. So you could also add something more basic to the standard B mode image of movement. B is for brightness, and you can add M mode, and that is motion mode. It's present on, I think, on every ultrasound machine because it was actually the first way of looking at this movement. So you can capture, someone is positioning an M line in the video here, right? At the edge of the diaphragm in this case, because this is diaphragm movement. And then if you start the M acquisition, you get what's called an M line. Here are some measurements being performed, and we're going to see what that M line results in. So here again, you see the B mode image on the right, you see the M mode image, which is also called the beach with the sand on the left. And if the patient breathes in, you can see the diaphragm coming into the picture. Okay, but we're not looking at diaphragms here, we're looking at tremor. So this is a still image of an M mode of someone with Parkinson's. And in the M mode, you can actually see the frequency of the muscles moving, right? So that's this line below here that can capture the frequency of tissue movement for you. So that sounds interesting. But what do you need? Well, at first, you really need to optimize temporal resolution. So you want the highest frame rate as you can possibly get. And that usually means the lowest depth setting. So the machine can use all the ultrasound to get a good frame rate. And you can also improve resolution by, for example, removing scan lines. But then again, the temporal resolution will be better, but the spatial resolution will get less. So several tricks, and you might want to optimize them for use in your practice and research. Manual scanning can be a bit of a challenge. So this is a patient with a dystonic tremor, quite severe, and you can see my hand trying to hold the ultrasound probe still over the deltoid, but just because the movement amplitude is so large, it's actually quite difficult to keep a fixed position there and not sort of compress the muscle or, hold it in place, because that's not what you want either. So this is kind of tricky. And what might be helpful is something like this. There is a small startup company, Usono, that actually makes custom probe fixation devices. So you can attach your probe to, in this case, a leg. They actually use this in people running marathons to look at the fiber direction change and the pennation angles, etc. But something like this might be very helpful if you're scanning a large amplitude tremor. So you could also look at the pattern in a limb. Here we're scanning the flexor region. FCR is flexor carpi radialis. Pronator teres is right next to it. They're sort of yin and yang, those muscles. And if I start the video, you can see the tremor, which is much more pronounced visually. And you can also quantify that in the pronator teres. So I think this might be one of the more practical uses at this point, is that if you want to inject this patient with botulinum toxin, I think you rather target the PT than the FCR, right? In this case, because it's probably more effective in reducing the tremor amplitude. And patients, they don't complain about frequency, they complain about the amplitude of the tremor. That's what's causing the symptoms and severity. Okay, so here you see we turn the M line on, and then you get just a single image line, which is the dotted, the dots that go vertical in the right-sided image. And so FCR is overlying this. Sorry, I couldn't get rid of that. But you actually see the pixels moving in that single image line. So here again, that dystonic tremor. And just looking at it, you can see that one part of these muscles is much more active than the other. Okay. So the PT might again be the primary candidate here for chemodenervation. Now, here is how you might detect frequency of a tremor. So this is a patient with essential tremor, large amplitude. We're looking at biceps brachii here. This is rest. And then you see the tremor amplitude go down in the images. And here's the video again during elevation of the arm. Well, you can sort of gauge that. You can count the seconds that are on the M mode line and then recalculate the frequency, right? So that's what we do. This is sort of a helpful tool. You can do that in a MATLAB script or maybe Python if you have a programmer at hand. And you can extract the frequency spectrum. And you can see here that this is a 4.6 Hertz frequency. So this is a frequency spectrum enlarged. And you see the harmonics of it as well. But this is the main prima frequency in the muscle that we see, okay? So this is, I think this is, takes a little bit of programming, but you could put this out as a, open source tool, for example. So same example here with a dystonic tremor. It's a triceps tremor, high amplitude tremor, and then enlarging the frequency spectrum, you see that it's at 5 Hertz, that's the main frequency. And then you have the harmonics at multiples of 5. Okay. Now, fun thing to do is to match this with a polymyography recording. So here we have the same patient, the dystonic frequency. You can see the ultrasound image lined up on the right with the 5 Hertz spectrum, and you can see the exact same spectrum there, the FFT of the tremor transducer. So there's a good match in this case between the two techniques. Now, a colleague of mine, Alexandra Borchert from Aachen, actually pointed me out that she had a colleague who used to measure tremor this way. You have a small ultrasound probe, you just hold it in your hand if you have a distal tremor. You lay your thumb on top of it, do not, crunch it or just casually, not too much force. And then you can capture a tremor with the M line just by holding the probe and having it move. So that's an elegant way for these very distal tremors probably to capture them. The other thing is that ultrasound doesn't only see tremor, but it sees every movement that the muscle is making. And that can become, can be a complicating factor in, for example, assessing frequency. So this is a patient with an orthostatic tremor. This is the polymyography. I think it's a small video of the surface EMG recording here. We do that on an EEG machine, actually. Patient is just sitting, not a lot going on here. The patient has consented to his use of his material. So when he's getting ready to stand up, my colleague, Dr. Jort Wijntjes, has to come and collect all the wires hanging from his head to make sure that he's not stuck. So here, he's going to make the transition to a weight-bearing position. So and now you can see this fast tremor in his quadriceps. And that is the orthostatic tremor itself. I think at this gentleman, it was a 16 Hertz tremor. That was both visible on the tremor transducer, but also in the EMG polymyography signal. So here is the frequency spectrum. Yep, 16 Hertz, very classic orthostatic tremor, all the right complaints in his case. Now, this is his rectus femoris with ultrasound during standing up. So there are a lot of irregular movements. The leg itself or the whole scan area is sort of moving around. And I'm not quite sure if I'm seeing anything that's related to the 16 Hertz frequency here. There's a lot going on, but I wouldn't, at first sight, classify this as a classic orthostatic tremor. So this is the M mode of it, and you can see where the position of the probe was, so in the middle of the rectus femoris. Yeah, well, it's moving all around, and you see some tiny trembling sometimes, but not very consistently here. So we were sort of wondering what's going on in this case. Well, it might just be that these very irregular movements, you can also observe them in the video if we zoomed out or just looked at the patient at the time of the recording. But there's a lot of compensating muscle activation for him to be able to stand. So it's not just the tremor that's going on in his leg muscles, it's also activation to sort of keep his balance and not fall over. And that is something that the ultrasound will also show you. So you get this combination of, on the one hand, the tremor, but also the compensating movement. And that's what's complicating this picture here. So next thing we thought was, can we maybe try a smaller anti-gravity muscle to see if we can have a better correlation between the ultrasound and the polymyography? And then we tried his arm muscles. Very high frequency here, 79 frames per second that you see here in the image, the triceps, and he's going to bear weight on it. So we just ask him to bend over and then all of a sudden put all his weight on his hands so we can see the anti-gravity effect of this orthostatic tremor. And yeah, there is some tremor now, and it seems to be high frequency. But again, here's the M line, by the way. So yeah, there's something going on, but the question is, can we extract this? Okay, so we tried, and we took the nicest segment, which you are showing you here on the left, so the tremor part that is sort of in between these two M-line regions, and we tried to extract a frequency spectrum. Well, as you can see here, that's not very successful, right? There is no dominant frequency. I certainly don't see a 16 Hertz component here. So we talked with the manufacturers and looked back at our presets, and we think that just currently the image line resolution and the refresh rates of the video are not sufficient to detect this high frequency 16 Hertz tremor yet, and then you have the compensating movements. So these are complicating this. So right now for orthostatic tremor, I would stick to the stethoscope, right? Or the polymyography, not go to ultrasound yet. So that sort of brings us to our conclusion at this point in time. This is all brand new, but preliminary scan tips for ultrasound of tremor would be that you need a good preset that has an MSK setting, a high enough frame rate, try to aim for example, 40 Hertz or more, turn your image smoothing software off, and make forward video loops, like 15 to 30 seconds. Then take the shallowest image depth, so you get the maximum frame rate. Combine the B mode and the M mode image and make videos of that. And then if you're interested, just extract the M mode frequency. You can also visually assess it because you know what 1 second is in the image, and then you just count, right, waves, but you can also use one of those short scripts. And what you really want in your image is a bright bony surface or a bright fascia, because those will give you the nice M-line movements. So what's next? Well, I think the first thing we're going to try and do is see if it not only helps us, put the needle in the right spot, but also guide us in which muscle is most dominant in causing a tremor amplitude, and then put the botulinum toxin or other, chemodenervation methods in there. What would be really interesting from a research perspective would to see if we can combine ultrasound with polymyography more regularly to see what the relation is between the primary motor unit firing rate and the tissue displacement that follows. And then ultimately, you would also want to link it to another part of the chain, which is the EEG and brain coherence. But I think that one is one step further away at this time. So that's where we are at with the ultrasound of tremor. Again, we would love to hear your opinion. So leave a comment or email or message us, and we would love to discuss with you. And again, thank you very much. This is one of my favorite cartoonists, the Awkward Yeti. Please check him out. Thank you.